The following podcast is part of a certified educational activity titled Stepping Forward to Transform Mantle Cell Lymphoma Management, Guidance on the Selection and Use of Bruton Tyrosine Kinase Inhibitor Platforms as First-Line Therapy. Access the entire activity and complete the post-test at peerview.com/QHV860. Downloadable slides and practice aids are also available.
Good evening. You know very well that the title of this symposium, Stepping Forward to Transform Mantle Cell Lymphoma Management, Guidance on the Selection and Use of a BTKi inhibitor platform as a frontline treatment. And I am Pierluigi Zinzani. I am professor of hematology in the Institute of Hematology of University of Bologna, Italy. And my colleagues tonight are Dr. Toby Eyre from University of Oxford, UK, and Dr. Christine Ryan from Dana-Farber Cancer Institute in Boston, Massachusetts, United States. So, this is a very interesting table. BTK inhibitor regulatory status in mantle cell lymphoma concerning the comparison between EMA official indication and FDA official indication. For the covalent ibrutinib first generation covalent BTK inhibitor, there is an approved in Europe after one prior line of treatment. In the United States, recently the indication withdrawn. For acalabrutinib, second generation covalent BTK inhibitor, for EMA, European Agency, there is a phase 3 trial. We can discuss during the presentation of Dr. Eyre. And in the United States, there is an approval after one prior line of treatment. Zanu, the second one in terms of second generation BTK inhibitors, phase 3 in Europe concerning the potential indication by EMA. And again, in the United States, according to the FDA, there is an approval again after one prior line of treatment. Concerning the two non-covalent BTK inhibitors, first one, pirtobrutinib, there is an approval for relapsed refractory mantle cell lymphoma after prior covalent BTK inhibitor, and in Europe and in the United States, the same approval, but after at least two or more than two lines of systemic treatment, including one of them, BTK covalent inhibitor. The other one, non-covalent BTK inhibitor, nemtabrutinib, is on phase 2 study. So a few words concerning the story. The long story of ibrutinib, long-term outcome with ibrutinib shows interesting, important, sustained clinical benefits in the setting of relapsed refractory mantle cell lymphoma. All of you know this data published recently, 2 years ago, by Martin Darling on Hemasphere concerning an update with a follow-up of 10 years of the famous 370 patients included in the pooled analysis that were published the first time 7 years ago by Simon Roll and co-workers. The overall median progression-free survival and overall survival of 12.5 and 26.7 months was observed respectively. And you can see the two curves of progression-free survival in terms of best response for patients who obtain a complete response and for the patient who obtain only a partial response with a huge difference. In terms of median progression-free survival, according to the stratification of the patient who received one prior line of treatment, the median progression-free survival is close to 26 months. On the other hand, for patients who received more than one prior line of treatment, the median progression-free survival is 10.3 months. These are the final data from the registration study of acalabrutinib as a single agent in the treatment of relapsed refractory patients with mantle cell, published by Michael Wang, and this several years ago. There were several updates, and you can see here that all these patients received at least two prior lines of treatment with a range between 1 to 5. The median age was close to 70 years, and the overall response rate was 81%, with 40% of the patients who obtained a complete metabolic response, because the evaluation of the response was according to the Lugano criteria 2014, utilizing CT scan and PET scan. The median duration of the treatment was roughly 14 months. After a median follow-up of 38 months, the overall response rate is 81%, and the CR rate is 48%. The median duration and the median progression-free survival were 29 months and 22 months, respectively. And finally, the median overall survival was close to 60 months. At the same time, there is a longer follow-up. With the longer follow-up, there is a confirmation concerning the efficacy of zanubrutinib, the second generation covalent BTK inhibitor, in the same setting of relapsed refractory patients. There was a publication by Dr. Song from China. You have to remember that these patients, 86 patients included in this trial, were all patients from China. And after a median follow-up of 36 months, the overall response rate is 84%, and the median progression-free survival is 33 months. You have to remember at the end of the day that according to the Lugano criteria 2014, the CR rate, the complete metabolic response using zanubrutinib in this setting of patients was close to 78%. Also, chemoimmunotherapy is quite effective as upfront treatment. Outcome with early progressors suggest better options that we need. And you can see here some data published by Bond and co-workers 3 years ago on Blood Advance concerning the different duration of first remission according to the concept of POD 24, POD between 6 and 24 months, and also the POD within the first 6 months. So there are 3 different situations in terms of overall survival according to the training cohort, POD 24, POD between 6 and 24, and of course the last one is like a progression, we can consider like a primary, very close to a primary refractory. And the same situation is on the basis of the validation cohort of patients. Of course, in terms of predictors, TP53 mutated mantle cell lymphoma remains a really important unmet medical need concept. And the intensification of standard of care treatment in terms of regimen related to and specific for younger patients with mantle cell lymphoma do not overcome the TP53 mutation. This is one example published several years ago by Eskelon and co-workers. You can see here in the overall survival curves the real difference between the red line P53 mutated patients versus the non-P53 mutation, and the P was statistically significant. So our goals for today are improve your knowledge on current guidelines and evidence supporting the expanded use of BTK inhibitors platform in mantle cell lymphoma, including as first-line treatment option. Equip you with the skills you need to prepare for the use of modern BTK inhibitor option in the management of newly diagnosed mantle cell lymphoma. And last but not the least, provide you with guidance on practical aspects of modern mantle cell lymphoma care, including dosing and safety consideration associated with the BTK inhibitor-based strategy. And now I call friend and colleague Dr. Toby Ayer for the second part of this symposium.
Excellent. Thank you very much, Pierluigi. All right, great. So my topic is talking about managing patients with BTK inhibitors in the frontline treatment setting, and I'm going to be speaking about combining chemotherapy with BTK inhibition and the data that exists and is is coming soon. Okay, so immunochemotherapy really does remain part of the mainstay of first-line treatment for mantle cell lymphoma. These are recent NCCN guidelines from the United States, but you'll notice here that, as outlined in red, BTK inhibitors have joined chemotherapy in the frontline setting. So if you just run down these preferred regimes in younger, fitter patients receiving what's been defined as aggressive therapy, you can see cytarabine-based and rituximab-based induction is considered an appropriate approach, either with DHAP or alternating with MaxiChop or with R-bendamustine here. So those three regimes still remain very much standard approaches. I will show you data from the Triangle study to support this statement here, but you can see the introduction of a covalent BTK inhibitor in addition to the R-CHOP, so delivered with the R-CHOP in induction, is considered an appropriate treatment option. And you can see here that there are two different categories, category 2A for ibrutinib, category 2B for acalabrutinib or zanubrutinib. Ibrutinib was, of course, the BTK inhibitor that was delivered in the Triangle trial. Less aggressive treatment options used in older patients, perhaps not historically suitable for autologous transplant, include bendamustine rituximab, Valcade plus a CHOP-based backbone, R-CHOP, maybe R-squared as well. And in less intense patients, rituximab maintenance is considered, particularly after R-CHOP, where the quality of evidence is very high, supported by a randomized clinical trial, and often delivered after BR. And if you look at, for example, studies like SHINE, ECHO, as I'll talk about, and also the ENRICH trial, rituximab maintenance is delivered after BR in that setting. It's not recommended after RBAC chemotherapy. The phase 2 study that has been performed with RBAC didn't use maintenance rituximab, and so that hasn't really been analyzed. And then maintenance, when you do use a BTK inhibitor in induction, the Triangle study used a BTK inhibitor for 2 years, so for fixed duration, and that was alongside maintenance rituximab in most patients in that study. So guidelines in Europe are similar, but there are some nuanced differences. So this is a UK guideline published earlier this year, and you can see patients were divided according to fitness for autologous stem cell transplant. Still a sort of recognized division in mantle cell lymphoma. Again, similar recommendations for younger patients, including maintenance after autologous transplant and offering autologous stem cell transplant. Of course, that may depend on the availability of ibrutinib in that setting, and a recommendation was to consider ibrutinib during the induction, so performing a triangle-like approach in place of the autologous transplant if it's licensed and reimbursed in that setting. And older patients, very similar really to the NCCN guidelines. So as I mentioned, BTK inhibitors have been used in the first-line treatment setting and studied. The SHINE clinical trial took older patients, so those 65 and older, and randomized patients to bendamustine rituximab plus placebo, followed by maintenance rituximab versus ibrutinib, given throughout the induction with bendamustine rituximab and as continuous therapy with rituximab maintenance. And you can see here this study was positive in terms of a progression-free survival advantage. The median PFS for the ibrutinib-containing arm was just over 80 months, and the median PFS for the bendamustine rituximab plus placebo was about 53 months or so. But the arm containing ibrutinib was considerably more toxic. There were more toxic deaths in that arm. There was considerably more discontinuation due to toxicity, and ultimately there was no overall survival advantage for the use of ibrutinib plus bendamustine rituximab in this setting. And so this regime has not been formally approved in any geography around the world, as far as I'm aware. The Triangle study, however, a slightly different story, a different patient population. So this took younger, fitter patients with mantle cell lymphoma who were previously untreated. They were under 65. They had to be suitable for high-dose cytarabine and an autologous transplant, have a good performance status. And there was a three-way randomization in this trial. Now, I'm going to walk you through it because it's a little bit complicated. ARM-A is a standard approach, so CHOP and R-DHAP alternating as induction and an autologous transplant, and at the initiation of the study, observation. Now this was changed to rituximab maintenance when the study was enrolling because that became an approved approach in first-line mantle cell lymphoma. The first experimental arm, A plus I, used that same backbone but introduced ibrutinib in induction with the CHOP, not the DHAP, and then for 2 years of maintenance as fixed duration after an autologous transplant. And then the third arm, potentially the most interesting arm of the three, is the same induction with the ibrutinib, but not performing the autologous transplant, followed by 2 years of maintenance of ibrutinib, but again stopping there. And as you can see, fortunately, the arms were pretty well balanced for rituximab maintenance. So it was, once it became available, it was delivered routinely in all the patients within this study. The primary endpoint of the study was failure-free survival, which is a very similar endpoint to effectively progression-free survival. Now, there are a number of statistical analyses that have both been performed and actually still ongoing in this study. The first analysis performed was looking at superiority of the addition of ibrutinib to the arm where autologous transplant was still, to the two arms where the autologous transplant was still performed. And you can see a statistically significant improvement, a superior improvement in progression-free survival with the addition of ibrutinib comparing the two arms that had an autologous transplant with a hazard ratio of 0.52. Now, the other interesting analysis which is read out statistically is that patients who had an autologous transplant and no ibrutinib were not considered superior to the group that had ibrutinib alone, and actually a suggestion here that the ibrutinib arm looks like it may well be doing quite a bit better than the autologous transplant arm without ibrutinib. So overall, this certainly suggests that adding a BTK inhibitor in this induction and potentially as a maintenance therapy for 2 years really does improve patients' failure-free survival in this setting. So that is clearly quite different from the SHINE clinical trial, where there was no survival difference and considerable increase in toxicity, whereas actually in the Triangle study, particularly during induction, there wasn't much additional toxicity with the ibrutinib. The additional toxicity with ibrutinib really came after autologous transplant. But in those who didn't have an autologous transplant but did have ibrutinib induction, the toxicity profile looks very favorable. So what about acalabrutinib? We know BTK inhibitors have been studied head-to-head in other disease histologies, including CLL and WM, for example. There isn't that data in mantle cell lymphoma to date, but we do have clear data from other histologies that the second-generation BTK inhibitors, including acalabrutinib, do look favorable from a toxicity profile compared to ibrutinib. So the question, therefore, is will the combination of acalabrutinib plus bendamustine rituximab look similar to the SHINE study or different? Now, this is a phase 1b assessment of an early both relapse refractory treatment cohort and treatment naive cohort, suggesting that the combination was generally well tolerated with high response rates. And this has been presented last year at the summer congresses, and you can see here favorable survival in these relatively small cohorts. But this study was designed as an initial study prior to the randomized ECHO study. So this is a phase 3 randomized placebo-controlled trial of older patients in mantle cell lymphoma, very much like the SHINE trial in its design and size, again taking older patients requiring treatment with a good performance status and randomizing patients to placebo or acalabrutinib, both groups again having standard dose bendamustine rituximab, both as induction and with rituximab maintenance. And in the experimental arm, acalabrutinib was again continued to progression or toxicity, with the primary endpoint being progression-free survival. These are the key primary endpoints. So acalabrutinib plus bendamustine rituximab improved progression-free survival compared to bendamustine rituximab alone. You can see 66 months versus 49 months, and that represented a hazard ratio of 0.73, which is strongly statistically significant. I would state that there was quite a lot of COVID in this study. It was performed very much during the depths of the pandemic, and there were quite a few COVID events, both COVID-related deaths and also discontinuation due to COVID. And so a predefined sensitivity analysis was performed censoring for COVID deaths. given that there were actually increased deaths in the acalabrutinib and bendamustine arm. And what you can see here is when those events are actually censored, the hazard ratio improves down to 0.65, and the p-value becomes more statistically significant, and the median progression-free survival in the acalabrutinib bendamustine arm had not been reached. A similar analysis was done for overall survival. So overall survival, there was a hazard ratio of 0.86 with a p-value of 0.27 for the overall arm, so no statistically significant difference in overall survival. A sensitivity analysis was also performed here. Again, this was pre-specified before the trial fully read out. And when the sensitivity analysis was performed, the hazard ratio did fall and the p-value became 0.12. And so certainly a hint, a trend towards overall survival, but not statistically significant at present. And then just my final slide before I hand over to Christine. Acalabrutinib is also being studied in a large collaborative US clinical trial. I just highlight here, we haven't seen results of this, but it's certainly a very interesting study. This compared 3 different regimes, bendamustine rituximab followed by cytarabine, high-dose cytarabine, so a standard regime, a bit like the RBAC regime with those 3 agents. And then two other arms, 2 experimental arms, both with acalabrutinib, one in addition to that standard backbone and one in addition to the backbone but minus the cytarabine. So asking questions, how do these induction regimes compare, both in terms of response but also toxicity, with the primary endpoint being MRD negative CR at the end of induction. So we certainly look forward to seeing these results in due course. So that concludes my summary of some of the recent data, and it's my pleasure now to hand over to Christine, who's going to talk about chemotherapy-sparing induction using BTK inhibitors in first-line mantle cell lymphoma. Thank you for listening.
All right, good evening, everyone. So we'll jump right in. So as Toby said, I will be covering, now that we've discussed the treatment regimens combining BTK inhibitor with chemoimmunotherapy, we're going to turn our attention to regimens that are full of targeted agents only, so these, quote, chemo-free options. This is a summary table. There are a number of doublet and triplet regimens with BTK inhibitors that are in rapid development for mantle cell lymphoma. This list is a list of studies that either have reported data or ongoing trials, and we're going to, in the next 10 to 15 minutes, walk through the highlights of the data for each of these studies. So up here, we're going to look at the combination of ibrutinib and rituximab with acalabrutinib and rituximab, and then we'll move into some of the triplet regimens here, which are all built on a backbone, many of them of a BTK inhibitor with a BCL2 inhibitor and anti-CD20 antibody. So to get started, the first doublet regimen is that of ibrutinib and rituximab, and this was studied in a phase 2 trial at MD Anderson in older patients, so age 65 or older, with newly diagnosed mantle cell lymphoma. In 50 patients enrolled in this study, the overall response rates and complete response rates were excellent, as you can see, with a CR rate of 70%, and the responses were durable. However, as we have seen with the use of ibrutinib, particularly in older patients, there are a number of toxicity considerations, and the characteristic toxicities of ibrutinib were seen in this patient population. So as we know with these patients, in particular because of cardiac toxicity, careful evaluation is needed before starting ibrutinib-based regimens. Well, what about if we use a better tolerated BTK inhibitor? So MD Anderson group also conducted a phase 2 study of acalabrutinib in combination with rituximab in older patients, again, age 65 years or older. And again, it was a study of 50 patients. You see that the response rates, similar to ibrutinib with rituximab, are quite high. Overall response rate of 92% with a complete response rate of 74%. And in those patients in this study who they had MRD data available for, you can see high rates of MRD negativity. Now, the 2-year progression-free survival rate of this in this study was 90%, so very favorable. And this combination is also in active investigation in a study in the UK. Now, with the doublet data in mind, there has also been significant interest in triplet combinations. And so the first triplet regimen to be investigated was that of ibrutinib, obinutuzumab, and venetoclax, and this was in the OASIS-1 study. Now, very notably in this study, there were a significant portion of patients with higher risk disease. You can see here that 40% of patients had deletion 17p. And despite these potentially adverse prognostic features, durable remissions were observed in this study. And the response that was achieved was actually done so within the first 6 months of triplet therapy. So you can see that at the end of cycle 6, 2/3 of patients in the relapsed refractory cohort, as well as almost 90% of patients in the treatment-naive cohort, had already achieved a complete response. And in updated longer-term follow-up data, we see that in the frontline cohort, the 4-year PFS was 80%. Now, building on a similar backbone, there has been investigation of acalabrutinib with venetoclax and rituximab. So again, the same backbone of a BTKi with a BCL2i and an anti-CD20 antibody. In this study, in treatment-naive mantle cell lymphoma, there were 21 patients enrolled. Patients received the triplet regimen for 6 cycles and then continued with maintenance rituximab for up to 2 years. Now, this study, similar to others, unfortunately suffered from being conducted in the midst of the height of the COVID-19 pandemic. And so you see here progression-free survival curves that are both censored and uncensored for death due to COVID-19. It's of course hard to fully pull that out, given that with a triplet regimen, we do worry about increased infectious risk. But nonetheless, you can see that with these PFS curves, a very high rate of durable response, particularly when censored for those COVID-19 deaths, presumably due to the fact that those patients did not have access to antivirals or vaccinations due to the timing of the COVID-19 pandemic. You can also see, again, the very high overall response rates with this regimen, and for those patients who were with censoring for the COVID-19 deaths, the median duration of response has not been reached at 2 years. Now, a similar triplet that we are leading a study of at Dana-Farber is the AVO triplet. So again, acalabrutinib, venetoclax, but instead of rituximab, using obinutuzumab. This triplet has been studied in high-risk relapse refractory disease and with promising results, providing the foundation for investigation in frontline setting. So here are the preliminary results for that relapse refractory cohort. This was a cohort of patients who either had TP53 aberrant disease or were transplant ineligible. You can see very high rates of overall response. And so we are actively enrolling to a cohort in the frontline setting and are hopeful to be able to present those results soon. Now, one other triplet to mention that is not necessarily a BTKi BCL2 based combination, but builds on the R-squared backbone. So this is the combination of acalabrutinib, lenalidomide, and rituximab as a triplet regimen. This is a study out of Cornell, which looked at this ALR regimen in patients with previously untreated mantle cell lymphoma. You can see very high response rates, overall response rate of 100% with a CR rate of over 80%. And one notable aspect of this study was that treatment duration was guided by minimal residual disease. And you can see here the rates of peripheral blood MRD after 2 years were as high as 83%. And in looking at the PFS and OS curves, we see that with a median follow-up of just under 2 years, the 2-year PFS is quite favorable at 87%. And so we await longer follow-up of this regimen as well. Now, a final triplet that I will highlight is the bovin regimen. So this is back to our BTKi, BCL2, anti-CD20 antibody combination. This is the combination of zanubrutinib, obinutuzumab, and venetoclax. This was a study presented at ASH by Anita Kumar from Memorial Sloan Kettering. And a very notable aspect of this regimen in this study was that all patients had TP53 aberrant disease. So as you saw at the beginning of the presentation, TP53 aberrant disease, really an area of unmet need in mantle cell lymphoma. And this is one of the largest cohorts of a novel agent targeted regimen specifically for this patient population. You can see in looking at the response rates that a high response rate was achieved very early on in the study. So after only 3 cycles, you can see already a CR rate of 68% with an overall response rate of nearly 80%. And when we look at the best overall response rate, the total is almost 100% with an 88% CR rate. And then looking at the progression-free survival curve, thus far a 2-year PFS of 72%, which is quite favorable when we look at the data with historical controls of chemoimmunotherapy-based regimens in this patient population. So now let's turn our attention to the future, and I want to review briefly 3 randomized trials that are ongoing and for which we're awaiting results. These randomized trials include BTKi-based chemo-free regimens and have the potential, I think, to be practice-changing. So the first is the ENRICH study. This is a phase 3 trial of rituximab and ibrutinib versus rituximab and chemotherapy in older patients with previously untreated mantle cell lymphoma. So you can see here patients are randomized either to a standard of care arm with rituximab-based chemotherapy, which they receive for 6 to 8 cycles, and then proceed on to rituximab maintenance. And in the ibrutinib-based arm, patients will receive ibrutinib in combination with rituximab, again, proceed on to maintenance with ibrutinib and rituximab, and ibrutinib continues until progressive disease. So this trial is fully recruited, and we are awaiting the results, which we hope will be in the near future to be available. The next phase 3 study I'll highlight is the Mangrove study. This will, very similar to the ENRICH study I just showed you, investigates a BTKi with rituximab versus standard of care chemoimmunotherapy, in this case using the BTK inhibitor zanubrutinib. So patients in this study are randomized either to a zanubrutinib with rituximab-based regimen, where zanubrutinib continues until progressive disease or unacceptable toxicity, versus a standard of care arm with bendamustine and rituximab for 6 cycles, and then patients proceed to observation. So one notable difference here is that in this study, patients do not receive any maintenance treatment with rituximab. And then the last study that I will highlight is the OASIS 2 study. So this is a randomized study looking at a doublet versus triplet regimen, and to my knowledge is the first to actually directly compare doublet versus triplet head-to-head. The 2 arms will be an ibrutinib plus anti-CD20 antibody arm versus ibrutinib, anti-CD20 antibody, and venetoclax. So using that regimen of IVO, which was established in the OASIS 1 study, the OASIS 2 study will now compare it head-to-head with just ibrutinib and the anti-CD20 antibody. And you can see here the primary objective is set to include MRD, so it's the MRD rate in the bone marrow and our peripheral blood at the end of induction. So induction, as you can see in the study schema, is 6 months, then it moves into a consolidation of 6 months, followed by maintenance. All right, now we'll transition into reviewing some safety principles.
So, in terms of safety experience, I think it's very important to remember few elements. So don't give concomitantly with warfarin. For new onset atrial fibrillation, consider no warfarin anticoagulation plus monitoring. Hypertension, manage and hypertensive. Monitor for and manage cardiac arrhythmia, atrial fibrillation. Treat appropriately. Monitor patient for signs of bleeding, monitor for infection and secondary malignancies, and concerning in particular acalabrutinib, manage headache with acetaminophen plus caffeine, and for zanubrutinib in particular concerning neutropenia, for first occurrence dose interruption is recommended, and growth factor support for more severe manifestation. You see here in the picture the selected toxicity that you know very well, but you can go concerning the summing up about the comparison between the 3 different BTK inhibitor in terms of discontinuation to adverse event, 7, 6, and 9.3% for ibrutinib, acalabrutinib, and zanubrutinib, respectively. In terms of grade 0 more than 3 adverse events, in particular neutropenia was 16% for ibrutinib, 10 for acalabrutinib, close to 20 for zanubrutinib. In terms of major hemorrhage, 5%, close to 5% for ibrutinib, less than 1% for acala, and 3.5% for zanubrutinib. Finally, atrial fibrillation, 4.5% for ibrutinib and 0 for both acala and zanu. So the evidence from the SHINE trial concerning the safety experience, you can see here the death related to treatment emergent adverse event was roughly 11% for ibrutinib plus bendamustine and rituximab versus only 6% in the setting of patients with placebo plus brentuximab vedotin. This is the experience in terms of safety profile concerning triangles, so there are no difference in toxicity when adding ibrutinib to the induction treatment versus conventional chemoimmunotherapy. There is an increased toxicity with ibrutinib post-auto stem cell transplant. This is another reason to delay auto stem cell transplant. Acalabrutinib in combination, so acala plus rituximab, the most adverse event were grade 1 or 2, less than 1% were grade 3 or higher. Concerning the combination of acala plus bendamustine rituximab in the treatment-naive cohort, you can see here that in terms of grade 3 or more than 3, were roughly 17% for cardiac events, 17% for hypertension. Neutropenia was quite high, but this in this case is quite normal. And thrombocytopenia grade 3 and 4 was 11%. At the same time, the triplet, acala plus veno plus obinutuzumab, the cardiac events in terms of any grade were 19% and 0 in terms of grade 3 or more than 3. The same situation for atrial fibrillation, no events related to, no atrial fibrillation events in any kind of grade. Hypertension, only 1 cases in grade 3, no grade 4 and 5. In the ECOG study, the grade 3 or more than 3 adverse events were comparable and well balanced between ABR and PBR. Bowen, you can see here that the Bowen platform in terms of safety profile, the overall Bowen treatment was very well tolerated and safe. The most common adverse events were diarrhea, COVID-19 infection, neutropenia, and infusion-related reaction. Grade 3 neutropenia, 16% resolved with the use of growth factor support, and diarrhea was predominantly grade 1 and very well manageable. What can we learn from head-to-head evidence in other cancer settings? You can see here that the head-to-head trials confirm the hypothesis that more selective BTK inhibitors have fewer off-target effects, which contributes to less toxicity versus the first-generation BTK inhibitor ibrutinib. According to the Elevate trial in CLL comparing acala versus ibrutinib, and also the 2 studies, Alpine and Aspen, respectively in CLL and Waldstone, comparing Zano versus ibrutinib, and you can see the potential of target effect that they are included. Now we can move to the case discussion with the double role of Toby and Christine.
Excellent. Okay, so we've got a few minutes just to talk about 3 cases, and then we've got quite a few questions online, which we'll try and get through as many as we can to answer, and there'll be opportunity to ask questions as well, hopefully. So back to case number 1. So a reminder, this is effectively an auto-fit patient, so a young patient who is eligible for chemotherapy induction and auto-transplant. And I think the sort of discussion here is whether we feel that BTK-based treatment is a reasonable approach based on the current evidence and what the current thinking is in the EU and the US. So, and what factors might sort of determine the candidacy for frontline BTK-based treatment. So, Christine, could I come to you first? The sort of triangle-based regime is available in the NCCN guidelines. It's listed, and of course, different BTK inhibitors are listed. Be interested to know what your sort of standard approach would be here.
Yeah, of course. So, for us in the States, obviously, with Triangle using ibrutinib, which was voluntarily withdrawn from the market, the question is about extrapolating with other BTKs and substituting acala or Zanu. I would say at our institution, the standard, as you saw when Toby put up the NCCN guidelines, there are a number of standard of care induction regimens that are used in the US. And so at our institution, we generally use the bendamustine rituximab alternating with the rituximab high-dose cytarabine. And so for us, it's right now challenging to really know how to incorporate the triangle results into that, given that we don't yet have the BTKi plus RB-RC data. That is the backbone that's being used in the ongoing cooperative group trial, and so we're sort of awaiting that. But what I will say in terms of discussing with other colleagues in the States, that many have started to adopt a triangle-like approach using the R-CHOP, R-DHAP backbone, but adding in either ACALA or ZANU, sort of choosing one of the two BTK inhibitors. I think that the data is definitely compelling that adding BTKi to chemoimmunotherapy induction and maintenance does improve the failure-free survival.
Great, thank you. And Pierluigi, what about yourself? Do you have access to frontline BTK to be able to perform a sort of triangle-like approach as yet, or are there regulatory barriers still?
No, I started with triangle. I started. Of course, we have to buy according to the hospital ibutini, but I think for the patient it's very important. After the publication, the final publication, Lancet, we started.
Okay, thank you. Okay, and we've sort of really covered that. Sounds like, Christine, you're sort of happy to extrapolate the data from Triangle to use a second-generation BTK inhibitor in that setting. You feel comfortable doing that, and you're hearing colleagues are as well.
Yes, absolutely. I mean, I think that we know from other head-to-head trials of BTK inhibitors that, ACAL and ZANU better tolerated than ibrutinib. We have, at least in CLL, a signal of ZANU efficacy over ibrutinib. So I think that there's definitely data there to support that extrapolation if using that R-CHOP, R-DHAP backbone.
Great. Okay, so recommendations here. So assuming access to first-line BTK inhibitors, I think the recommendation for a patient like this enables the use of chemotherapy plus a BTK inhibitor enables a potential safe omission of autologous transplant with the benefits of that. And this, of course, is time-limited BTK inhibitor approach in the frontline setting, and it seems feasible and tolerable to do. So I think many people are doing that, depending on, obviously, access, of course, which is a major barrier globally. But I think if you have access to a BTK inhibitor, it's a very reasonable approach. So the second case, a reminder, this is a sort of older patient, performance status of 2, so would sort of fit into perhaps the enrollment criteria of the SHINE study or indeed the ECHO study. So discussion here, so what would this patient normally perhaps be a candidate for a BR backbone? I think I'd say probably yes. I mean, I might just want to sort of assess why the performance status is 2 and whether there's any sort of concerning comorbidities driving that. But certainly somebody of that age group would very much be in the group where you'd consider BR as a backbone. Is there a rationale for adding a BTK inhibitor, and how does SHINE and now ECHO inform the present and future BTK-BR combinations? Perhaps, Pierluigi, I could come to you. I'd be interested in your sort of initial views on SHINE versus ECHO and where you see the sort of differences there. Obviously, we haven't seen the full presentation and all the data, but from what we know, what are your thoughts?
No, I mean, the real difference between SHINE and the ECOG was that in the second line, the ECOG, there was a trend in advantage of the combination of BTK plus BR in terms of overall survival. It was fundamental because at the same time, when there was a submission to SHINE to the 2 different agencies, they want some trend in terms of overall survival. This was fundamental because another important point is the difference in terms of percentage of deaths when you compare the 2 different trials.
Yeah, thank you. And Christine, your views on what we've seen to date?
Yeah, I think, this is a patient population where if you were to maximize PFS, definitely the data with the first-line treatment, data does support adding that BTK inhibitor. I think it is also, though, interesting to think about concomitant versus sequential use, and this is a situation where if you were to start with BR and the patient gets a good durable response, could you then save your BTK for second line? I think that's still, we need some more data there. But I will say, particularly if the patient has TP53 aberrant disease or other high-risk features, I think that's a patient population where I would prioritize using the BTK up front.
Yeah, we'll be keeping our eyes peeled for the different subgroups, particularly the high-risk groups within the presentation for sure. Thank you very much. Okay, so I think our recommendations are certainly a current standard of care is BR plus minus maintenance. Rituximab, many people I think are delivering maintenance here. There are some clear differences between the SHINE and the ECHO study. I'd also state that the ibrutinib-based therapy in SHINE really was quite toxic. The median time on treatment was only about 2 years, despite a desire to continue ibrutinib to progression or toxicity. And so there are potentially some differences there, but obviously we look forward to tomorrow's presentation. And of course, as you mentioned, the question of sequencing of therapies, 2 treatments versus 3, or sequentially 2 and then 1, an age-old question, I think, in lymphoma, and one that I think still exists a bit here. But certainly we look forward to seeing more data on subsequent lines of therapy and so forth in the ECHO study, and see if we can tease apart that from the presentation. Okay, and then the final case, which is actually an adaptation on that second case. We thought it'd be useful to talk about this patient as if they were older, so 81 now, not 74, and a discussion about sort of chemotherapy sparing. So what strategies? I mean, Christine, you talked a little bit about this. You touched on this sort of age group potentially. Would you consider, assuming you had access to any treatment possible, what kind of therapy would you want to use in somebody of this age group, and why?
Yeah, I think this is the type of patient population where I would, strongly consider BTKi plus, we have the data for rituximab, so BTKi plus anti-CD20 antibody, whether that's ACALA-R, ZANU-R. The Mangrove study will be, I think, very important here to provide that phase 3 evidence, but in the interim, with potential access to BTKi, I think this is a patient population where, bendamustine, as we know, can be poorly tolerated, will require dose reduction, infectious concerns. So I think this is a particular patient where I definitely would prioritize trying to use upfront BTK inhibitor.
And Pierluigi,
absolutely,
something very similar.
I totally agree with Christine.
Yeah, and we have the ENRICH study, hopefully reading out fairly soon, which will give us an idea about how, for example, ibrutinib rituximab compares from a tolerability profile compared to R-CHOP or R-bendamustine. So that will also inform decisions in this kind of patient.
Yes,
so,
and I think we talked earlier that could also provide good foundation for then extrapolation to our second generation BTK inhibitors.
Absolutely.
Yeah.
Absolutely. So recommendations here, so doublets and triplets and non-chemotherapy based approaches do appear active in older patients. And of course, as with all of our patients, there's always a trade-off of toxicity versus efficacy, particularly in older patients with comorbidities. I think we've seen some challenges with triplets in older patients, so BCL2, BTK, CD20 are known to be a bit more toxic in older patients, so you might want to consider potentially using a doublet here, and I think that's what we were recommending. And I think we've got hopefully a few minutes to answer some questions quickly before we close. Yeah, so I'll hand over to Pierluigi.
So, thank you very much, Toby. There are some questions from the audience. One is thought on BTK inhibitor maintenance after upfront treatment. Any indication on what is appropriate duration of BTK inhibitors?
That's a great question, very open question. There have been studies sort of studying BTK inhibitor to progression. For example, the Mangrove study continuous zanubrutinib in the first line setting. The OASIS 2 study actually uses fixed duration therapy in both arms, so 2 years of ibrutinib or 2 years of ibrutinib plus venetoclax. So there are different strategies being assessed in clinical practice. I don't think we know what the optimum treatment approach here is. I think it will depend on the partner agents that are delivered with the BTK inhibitor, because it's very possible that continuous BTK inhibitor, sort of either by itself or CD20, may not control disease adequately to be able to stop therapy. We've obviously learned some of that from the CLL world. So I think a very open question at the moment.
There is a particular question for Christine in particular, because it's concerning the triangle study. No, this one. Is there any evidence supporting the addition of BTK inhibitor on the first line setting improves the outcome of blastoid variant mantle cell lymphoma?
So I think that we, in the subgroup analysis, we have seen promising data with BTK inhibitors. That variant often follows with P53 status, and so, particularly as we presented the bovine data, which is a triplet approach for those high-risk patients, I think that there is evidence that it's, potentially has good efficacy compared to our standard of care chemoimmunotherapy. But I think, as Toby was alluding to, particularly, for example, in the ECHO data, we await, subgroup analysis that I think will be more informative there.
Toby, how durable is response without using chemotherapy, for example, with a BTK and rituximab regimen?
Yeah, that's a great question. I mean, we haven't actually seen that much data with, a BTK inhibitor plus a CD20 in the first-line treatment setting. There was actually quite a large UK analysis because both ibrutinib and rituximab were available during some of the pandemic, and so there's a paper in Blood Advances quite recently suggesting that it's a very efficacious regime, but particularly good in lower risk disease patients. You might expect that, and we've got some phase 2 data. Most of the phase 2 data actually with BTK CD20 is in generally quite low risk patients. From the UK analysis, the high risk patients do progress relatively early, so it may be that it's not fully adequate for patients with particularly high risk features, P53, blastoid disease, etc. But I think we need more data there.
Last question before the summing up. What is the relevant role of triangle studies? What is the impact on stem cell transplantation eligible patients in clinical practice?
Shall
we
I?
are at the end of the...
I'll answer that. So,
of the life of auto stem cell transplantation consolidation in mantle cell. What do you think?
So, to my mind, the triangle data is compelling. I think if I were a patient, I would want the ibrutinib arm with no transplant. The failure-free survival looks better. I didn't talk about this, but there's certainly a sort of trend to OS benefit for the two ibrutinib arms. Actually, the formal analysis of that hasn't been done as yet, but it does look like we're starting to see an OS benefit, and you're able to omit the toxicities of an autologous transplant. Now, so to my mind, this is actually as much of an access issue as it is about the clinical data. And if I had access, I don't at the moment in the UK, to a frontline covalent BTK inhibitor, I would quite comfortably do a triangle approach and follow the I arm, so I without the auto at the moment. And the reason why I do that is the I plus the A arm, so ibrutinib and autologous transplant, look like they're sort of overlapping with the ibrutinib arm, and we know that the ibrutinib gives quite a lot of additional toxicity after the auto. So that would be my approach, and I'd happily offer that to patients.
We can call the funeral home for auto stem cell transplant. What do you think? It's time.
I agree. I think that it is going to be a practice-changing study, and I think that we are, again, addition of BTK, it allows the omission of that transplant, and I just echo what Toby said. I think when we have those conversations with patients, it's a very attractive approach to not have to undergo the auto transplant process. So I think that we will see much less of it.
Okay, so some take-home message after this 1 hour of symposium. A real Copernican revolution in the world of mantle cell lymphoma. The triangle and the ECO study, we completely changed the frontline treatment with the introduction of BTK inhibitors and the definitive deletion of auto stem cell transplantation. The advent of second-generation covalent BTK inhibitor and the introduction of the first non-covalent BTK inhibitor, pirtobrutinib, this is another important point. The potential role of triplets, OASIS, ALR, AVO, Bowen, WIND-2, for the subset of high-risk patients. The forthcoming arrival of definitive data from the ENRICH study from the UK and the Mangrove trials. And let's not forget the role of T-cell engaging therapy. Recent FDA approval of the second approval in terms of product of liso-cel for the third-line management of mantle cell lymphoma after Baxter-cel, and also preliminary but very interesting data concerning the role of glofitamab, also in patients who failed CAR-T. All these data point to and will inform a new therapeutic algorithm and continuous and dynamic evolution, which will significantly raise the bar of therapeutic successes for our patients with mantle cell lymphoma. Thank you very much for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PeerView, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/QHV860.